Hey y'all. All right. So today, this week, rather, I'll be discussing Weber versus Rinne and conductive hearing loss versus sensory neural. I have previous videos on this YouTube channel that you can see that, but I want to go at it from a different angle just because I get a lot of questions in my one-on-one sessions with my review students with just trying to understand it. They easily mix it up, and I remember being in that state, so I just want to kind of break it down, like going back from the foundation standpoint and going over each factor, showing you the Weber versus Rinne with the actual tuning for it. First, I usually do it with a pen or whatever I have right here with me, but I wanted to do it to give you a little bit of a better example so that you can visualize what I'm talking about with the foundation. And then, throughout the week, I'll give you something else with just some little tips to kind of see it in a chart format. And then, on Wednesdays, we will work out practice questions geared towards this, etc. Okay? So follow me for the week. Subscribe to the channel so that you don't miss any of the videos and notifications. Okay? All right. So starting from the top, I like y'all to understand the basics so that you can, when you get stuck, kind of work your way through. So when we're doing this Weber versus Rinne, whenever doing those two exams, we are trying to figure out conductive hearing loss versus sensory neural hearing loss, right? So you're going to have this patient that's presenting to you complaining of changes in their hearing, maybe completely having hearing loss to a particular ear, right? But you're having some type of hearing loss, or they're complaining of a complete hearing loss to either their right or left ear. So these exams are testing for unilateral hearing loss, so understanding one versus the other. So conductive hearing loss is simply that the sound waves, the conduction of those sound waves are being blocked by something. Something in our middle outer ear portion is being blocked, either by cerumen, either a child has placed something in their ear. Something is blocking that sound wave conduction, causing the conductive hearing loss, right? Now, sensory neural, this is also a form of hearing loss, but the cause is not for something blocking that sound wave. It's more so something in that inner ear having a complication, or something sensory neural, something to the fact of like aging, changes in the aging, like presbycusis, or genetic factors, or things of that nature, like people working in facilities for a long period of time that had a lot of loud noise, and now it has caused these sensory neural deficits, right? So now that you understand those two, now we need to test and understand what is demonstrating with these exams, right? So then you have the Weber exam, and you have, I say Rinne. You have the Weber and you have the Rinne, right? And so with the Weber exam, it's going to see if the sound is lateralizing to either side. The sound should not lateralize, right? But if it's lateralizing to either side, if it lateralizes to the opposite side that the patient is complaining of, so the opposite ear that the patient is complaining of having hearing loss or any hearing deficits or changes, that is sensory neural. Now, if it lateralizes to the affected ear, so the ear that they're complaining about, if it lateralizes to that side, that is considered conductive hearing loss. Because why? If you go back to what I was just talking about, conductive hearing loss is simply something is blocking that sound wave conduction, right? The conduction of that. So it's going to go to the ear that they're complaining of it being affected, because something is blocking the sound in that ear, right? All right. Then, so we'll do the Weber first to look between the two, sensory neural versus conductive, kind of get us on our path, right? And then the Rinne, whatever you call it. It is done by also examining this, but it is checking specifically air conduction versus bone conduction. And when we are looking at that, it's going to also confirm that conductive hearing loss, right? So that'll be our secondary exam. It's also a quick source to see conductive hearing loss. But when we are trying to gauge which is which and what we have, we want to do Weber, then Rinne, okay? All right. So now that we understand conductive versus sensory neural and Weber versus Rinne, I'm going to tell you how to do the test, right? So, tuning fork. Standard tuning fork. Y'all seen it before. If you have not, tuning fork. And so what you're going to do, Weber test, you're going to strike the tuning fork. All you're going to do is hit it on your hand. Then you will place it at the center of your patient's forehead, right? They're going to hear the sound from the tuning fork. You're asking them, does the sound lateralize to either ear? Okay, and so that's why I say Weber starts with W, and it makes me think, you know, Brittany's brilliance. It makes me think of the emoji, like the shrugging shoulder emoji, where it's like, and that kind of makes the shape of a W. So does the sound lateralize to either ear? Does it lateralize? Is how I picture it. So the sound should not lateralize to either ear. Again, strike the tuning fork for Weber, place it in the center of their forehead, ask the patient, hey, what ear do you hear the sound best in? Does the sound go to either ear? They should tell you no. They should be able to hear it equally in both ears, right? Okay, cool. Now, so what if it lateralizes? So I'm going to give you a scenario. So I come in, I'm complaining of, and you know camera's flipped, but this is my right, okay? My right hand, my right ear. I'm complaining of having hearing loss to my right ear. So with the hearing loss to my right ear, whatever has happened, I've noticed it muffled, or I really can't hear out of my right ear. I can hear clearly on the left side, but something's going on over here, right? So right ear is the affected ear, okay? That's what we're rolling with for this scenario. All right, so if you're doing the Weber, strike your tuning fork, place it here, and patient says, I can hear the sound better on my left side, right? Okay. As the provider, you'll start to think, this is sounding sensorineural, right? Because sensorineural lateralizes to the opposite side of the affected ear, the ear they're complaining of, the ear that's the problem, right? Okay. Other example, bam. Does the sound lateralize? Do you hear the sound in either ear better than the other? Yeah, it actually lateralizes to the right. Well, I can hear it better on my right side. You're going to think conductive hearing loss because the sound will lateralize there. It's these different people tell you, and they'll tell you, like, if you try to block your ear and make a sound, you will hear it. I believe it's Barkley that speaks on that, but it's a good test to try it out. But that's conductive hearing loss. Thinking of something in there, and that sound, those sound waves are going to lateralize to that side, okay? Got it? Got it. Tell me if you got it. Put your shrugging shoulder emojis in the comments if you got it and the Weber exam makes sense now. So now, okay, we have gotten this thing broken down. We're going to keep the same scenario. Patient complaint, right ear being their issue. But we've done the Weber exam. Let's now do the rhyme. So what's the rhyme? Renee, Rinne, whatever you call it. I want you to go by however you know it, right? So again, tuning fork, we're going to strike our tuning fork, and then you're going to place it on the mastoid bone behind the ear, right? This mastoid bone is testing for bone conduction. And you tell the patient, let me know when you no longer can hear the sound. So they keep it here. When the sound stops here, you then place the tuning fork in front of the ear. And they should still hear sounds here. You tell them, let you know when they finish hearing the sound. When it stops, then you can stop doing the exam. So what does that even mean? Let's think about what we just did. Mastoid bone is bone conduction, right? And then when we place the tuning fork in front of the ear, this is the air waves. This is air conduction, correct? So what you have to understand with the Rinne exam, air conduction should be greater than bone conduction by a 2-to-1 ratio. And you don't have to go so deep with the 2-to-1 ratio, but I'm just trying to let you know that a normal finding is that air conduction, also known as AC, air conduction, is greater than bone conduction, BC, right? So it's normal as long as the air conduction is greater than the bone conduction. If you strike this tuning fork, bam, place it on the mastoid bone, tell the patient, let you know when you can no longer hear it. okay, I no longer hear it. And then you place it and say, hey, now let me know when you no longer hear it. They say, I don't hear anything. That lets you know that the bone conduction is greater than the air conduction, right? Because the reason that AC is greater than BC, if you do this first at the mastoid bone and move to air conduction, they should still hear. If they can't hear it, that means the bone conduction is exceeding their air conduction, right? That's an abnormal finding and key indicator for conductive hearing loss, right? So you will do both sides. If you see, if this side is normal because they didn't have any complaints, fine. If they have bone conduction greater than air conduction on this right ear that they were complaining about, the affected ear, conductive hearing loss, right? Okay. So you know I know I throw a lot at you, but I like to run it back. So let's run it back to the top. All right. So conductive hearing loss versus sensorineural, right? What is it? Right? So let's think about it. Conductive, we're talking about something that's blocking that sound wave conduction to the middle or outer ear portion, okay? It can be cerumen, it can be something in the ear. Something is blocking those sound waves, right? So when you do your Weber exam, the sound will lateralize to that ear the patient is complaining of, the affected ear, if it's conductive hearing loss. With the Rinne test that you do, the bone conduction is going to be greater than air conduction if this is conductive hearing loss, right? Now, sensorineural hearing loss. This is something from an inner ear problem or a sensory neural organ deficit or issue. And these things can be related to, like I said, aging complications like presbycusis, genetic factors, or being in scenarios where you have chronically been exposed to just loud sounds frequently, right? And so with that, when you do that Weber exam, when you strike that tuning fork, place it on their forehead, the patient is going to state that the sound is going to lateralize to the unaffected ear. So the opposite ear they're even complaining about. So you remember in our scenario, they came in complaining about their right ear. So the sound they would hear better in the left ear, right? And the Rinne is, again, a conductive hearing loss exam. So that's just testing for that. Okay, so we want to do the Weber first. We're kind of differentiate between the two. Rinne is an additional test, confirmatory, so to speak, but you can also do that as a quick assessment for conductive hearing loss. So I just wanted to hit those points really quickly to kind of give you a better understanding example, and hopefully that when you're doing these test questions, you're able to decipher it a little bit easier because you're not getting so hung up in your head and confusing the two, because you know they like to ask, like, is the affected ear is what they're complaining of and the sound lateralized here, so is it sensory, is it conductive? And you're like, wait a minute, the affected ear, unaffected ear, what did they say? You know, what exam did I do? So I wanted you to have a clear understanding of conductive hearing loss versus sensorineural hearing loss, Weber versus the Rinne, how you do it, see it with the actual tuning fork with the steps so you can see it's really quick and easy, so that this is something that you are not getting overwhelmed with and can easily do well and succeed on exams as well as in practice, okay? So let me know if you found this helpful. Please like, comment, subscribe. Make sure that you're hitting the bell so that you are getting the notifications so that you don't miss any of the videos. Again, all week we are covering this topic. Tomorrow will be tips and tricks on it to kind of just see it better in a format. And then, you know, we'll be working out practice questions to kind of test your knowledge and see how you're doing with it. Okay, so make sure that you're just practicing these things. You know, I always talk about also doing like a scratch sheet if that's helpful for you, to write it down so that you're able to retain that information. Okay, write that thing out so you can see it. Tomorrow I'll give you something so you can screenshot or whatever you want to do to help with that studying. But yeah, and share, please share with a friend. Let people know if you think this is helpful so that they can get benefits from this knowledge too. Helps with the algorithm so that more people can see it. I appreciate you guys. Also, lastly, a little housekeeping. You know, my new review book is on Amazon. Just search. Just search my name, Brittany Weinstock, just like it sounds, Weinstock, WINESTOCK, on Amazon, and you'll be able to get the my review book. It is the 3rd edition that is out, and so it's broken down in a fashion where you'll receive the content. So how I just told you that, it's broken down in systems that way. Then it has an interactive section for you to write it out in the format that I talk about things: assessment, diagnosis, evaluation, and treatment. And then it also has a medication list and practice questions in there as well. And then one last thing, we have my 5-week intensive course for my family nurse practitioner and adult geros, testing on either the AANP and ANCC exam started next week. So next Monday, June the 12th, class starts. So Wednesday will be the last day to enroll. The link is in the description. So please, if you want to join us, pop on in, click that link to enroll in the class. What we'll be doing in the class each day, we'll be covering a topic. You'll know what we're covering. I will give you an assignment. It will be things like this. I'm breaking down every area to make sure that you have the full understanding and knowledge of the content on each area that we do, go into the basics. Then I'll give you an assignment. Please, please, please do the assignment so that you are getting the benefit, the full benefit from this, because there's a method to my madness. And then we'll do weekly live sessions where I do practice questions. I'm thinking about doing 2 sessions because I have a lot of people in different areas and people with different work schedules. So I think I may do a morning and an afternoon just to accommodate everybody in the class. But I'll be sending that out Wednesday with everyone once we finish with enrollment, okay? And then at the end, that final week, so we'll do that for 4 weeks, and week 5 is a more individualized approach. Because think about it. Have you been in things and it's like, all right, I got the information, but I need to know how to apply for me. Did it work for me? How I'm doing? So that'll be the week that we are testing to see where you are. I'll give you personalized feedback and advice on what to do moving forward. Are you ready? You know, or X, Y, and Z, what you should do. All right, again, that's in the description. Click the link to enroll if you want to join us, and meet me back here, you guys. Bye, y'all.